career trajectory in global health and global health surgery. She's also going to be my able advancer for slides. So next slide. And when we start to discuss global health at any sort, we really feel it's important to go over what we're talking about. And in this case, we're talking about global health, which is an area for study, research, and practice. Next clip. That places a priority on improving health and achieving equity in health for all people worldwide. Next slide. Global health emphasizes transnational health issues, determinants, and solutions. It involves many disciplines within and beyond the health sciences and promotes interdisciplinary collaboration, and is the synthesis of population-based prevention with individual-level clinical care. Next slide. It is all about understanding the causes and finding the means to provide solutions to the challenges and disparities in health status of people worldwide, from Milwaukee, a neighborhood, to Madagascar, and really in the context of what we're experiencing as a planet with COVID-19. This is really, you're seeing the good and the challenges of global health in our planet as it attacks the COVID-19 pandemic. Next slide. One of the areas that Dr. Martin alluded to was my work with the Milwaukee Global Health Consortium. We recently commissioned a report that outlines the greater Milwaukee global health activities, businesses, academia, government. And this landscape study really is another element of what's happening in the greater Milwaukee area and Wisconsin in regards to global health. And for those of you who wish to receive this full report or executive summary, we'll be happy to send it to you. It is remarkable what is happening in the greater Milwaukee area and in Wisconsin for global health. Next slide. In addition, universities are coming together to share experiences, and the university is really becoming a transforming force in global health through research, education, and service. And the Consortium of Universities for Global Health was started in 2008 with a handful of the leading institutions. The Medical College of Wisconsin has been a member since 2011. And the annual meeting, which occurs in the spring, that CUGH sponsors, really is the premier global health conference in the world. Next slide. A brief history of international and global health engagement at the Medical College goes back to, maybe you can turn off, put yourself on mute. Thank you. In 1981, Milwaukee established the Wisconsin Indo-Chinese Refugee Relief Fund. It was started by a faculty member of MCW in partnership with a community leader, and that work advanced for several years. In 1986,
I'm trying to get that.
Okay, hopefully we can get that muted. MCW becomes a consortium member of the new Milwaukee International Health Training Center, which was renamed the Center for International Health several years later. MCW established an Office of International Health, which was renamed the Office of International Affairs, which our very own Leslie Martin headed for several years. 2002, Family Medicine initiated an international health training track. Pediatrics initiates a global health training track in 2008. And as you can see now, MCW is pulling in its learners. MCW has a pathway now with global health, a global health pathway. And I was named the inaugural Associate Dean for Global Health in the Global Health Program under the Institute for Health and Society. We've become a member of the consortium. Schroeder is entering into international patient programs. A Global Health Nursing Committee at Schroeder is established. And now there's a Global Health Program, becomes now a standalone administrative department and is now being referred to as the Office of Global Health. We now have a master's degree in public health program that created its first introduction to global health. And I referenced the Milwaukee Global Health Consortium. And now there's the impact study that I referenced. And now the Medical College has a master's in global health equity, which matriculated its first cohort this past year. So you can see there's been a steady engagement of the Medical College of Wisconsin, and really we're attracting a lot of great faculty, and you're going to hear from one of them shortly. And we're very, very excited about how global health is growing at the Medical College. Next slide. And it starts from the leaders. Dr. Raymond, I'm very pleased that we continue to demonstrate a true spirit of cooperation with academic partners around the world. Next slide. And Dr. Kirshner, our provost and executive vice president dean, MCW's knowledge is changing the lives of individuals and communities across our city, region, state, nation, and even the world. So our leadership is very much engaged in advancing global health at MCW. Next slide. We have integrated our global health efforts across the 4 missions of the Medical College. Next slide. Our office is run by Tiffany Fraser, who's the program manager, Amber Rios, our coordinator, and the 3 of us really want to work with faculty and students across these missions of the Medical College of Wisconsin. Next slide. In global health and education, we span the graduate school with a PhD in public and community health, master's in public health that I mentioned, and the new master's of science degree. In medical school, our medical students have the option of being in the global health pathway from the first year, M2 year, with the option of the 3rd year. There's a summer research program supported by the Kohler Family Foundation, which we are very appreciative of. And M4 students can have electives that are taking place in other parts of the world. Our pharmacy school will be forthcoming with their global health interests. And we're recently now initiating a Scholars in Global Health for our residents and fellows beginning in January. So across the spectrum of learners, we are integrating global health and education. Next slide. And the Kohler Scholar program that I mentioned has partnerships and experiences across the globe. We now have had 71 scholars who have gone through our program. We're very proud of these students who then go on to their residencies and careers. And we feel this has been a major imprint on their careers. Next slide. And as you can see, there's a continued participation of M4 students for electives from these last years that we've been accounting for them. Over 550 students take advantage of this. And we're hoping that once COVID begins to recede, that we can re-engage the students to have these global experiences in countries around the world. Next slide. Again, our electives are scattered around the globe, and you can see it's not. You can see that our elective countries are in this order, and we're really proud of these long-standing relationships that we've had with colleagues in these countries. Next slide. And the students really gain significant elements of their training with character, caring, and competence, which is consistent with the Kern Institute that's transforming education for our students. And really, we're proud of how this impacts our students in many, many different ways. Next slide. And our faculty are pulling in international scholars, you can see, in a variety of disciplines. And these scholars, again, this program has been changed into a mostly virtual program, but we're really pleased to have our learners on campus when it's possible in the coming months. And we really are pleased to be able to share our interests and our specialties with learners from across the globe. Next slide. And so we're dedicated to partnering with faculty across departments, institutes, and centers at the Medical College of Wisconsin. Next slide. And this is an example of faculty efforts in China, Asia, including China, India, and other places in the Middle East. We have over 150 active faculty, active engagement from 102 faculty, 53 countries, 26 departments. And you can visit our website and you can see the reach and scope of our global health activities of the faculty and departments. Next slide. And since we've become very organized with our global health activities, we've advanced formal relationships in a variety of countries, all faculty led, all demonstrating commitment to making a difference, whether it be in Belize, Ethiopia, as Dr. Martin mentioned with Dr. Schroeder, or Nepal or India. We really value that commitment from faculty to have genuine partnerships to make a difference with these relationships. Next slide. And so without further ado, I'd like to have Dr. Schroeder present herself and tell us about her story. We're very pleased that she's joined the Medical College of Wisconsin faculty. Dr. Schroeder.
Hi, thank you for this opportunity to speak to you all. We just moved to Wisconsin in June, so it's quite a time to be moving to a new area, and we've managed to meet great people, including Dr. Hargarten, and he has been so wonderful to give me opportunities like the opportunity to speak to you all tonight. So this is going to largely be a pictorial talk, because those are the kind that I like. Showing you predominantly what we have been doing in Ethiopia in the Division of Trauma with a program that we're involved in with the American College of Surgeons, with a smattering of some other areas as well that I've been involved with over the course of my training and career. So I became initially interested in global health and global surgery all the way back in undergrad. I spent time living in Kenya during a semester abroad. I've had the opportunity to spend time in, this picture of me was from my 4th year of medical school. It actually turns out that scrub dresses are quite nice and well aerated if you're operating in the middle of Zambia. I've had an opportunity to do trauma fellowship training in Colombia. I've done mission work in Guatemala, and now again spending a good chunk of my time devoted to our work in Ethiopia. And as a result of that, I've learned a number of lessons, and I'm going to go through some of them tonight. The first one being that global surgery, despite what it used to be, has evolved and is really not just about operating. When we go to these places, there is a bit of operating that goes on. This is a picture, the one on the bottom right is of me as a resident, taking one of my junior residents through an inguinal hernia in Guatemala. But the more time I spend there, the less time I operate, and the more time I spend teaching and really just observing. The picture on the bottom left was one of my old residents from New Jersey who went with me on a recent trip to Ethiopia and spent a bunch of time with the pediatric surgeons doing a bunch of very interesting cases. Again, I spend a lot of time walking around observing. And then what I actually spend the most of my time actively doing is a lot of teaching. So giving lectures to a variety of residents and faculty members. I'll talk about a bit more of that work and how it's pivoted during the times of COVID. This picture in the middle was a picture of me. They thought this was very funny in Ethiopia. They forced me to get up and read all the graduation certificates after an orthopedic trauma 3-day course, and laughed as I struggled through about 40 Ethiopian names. I've worked with residents, faculty. The picture on the bottom right is me giving a lecture to the 1st and 2nd year medical students about some basic trauma care at the medical school there in Ethiopia. So this is how I spend more and more of my time. I also spend time doing things like organizing storerooms. All the donations that come into a lot of these hospitals get stuffed in a room, and then going around trying to figure out what is actually there and what can we do. My resident Rachel and I, when we were there last November, actually realized that they had enough supplies for us to put together an entire laparoscopic sim center. So we convinced the medical school to give us a room. We convinced somebody else to give us some computers, and we set up a total of 6 lap simulators with the goal that they start gaining some basic laparoscopic skills with one of the kind of long-term goals of getting them to be able to do some basic laparoscopy, particularly gallbladders is what they're most interested in. So again, not necessarily what you think of when you think about global surgery. Again, here's some pictures of us walking the residents and faculty who were extremely interested through a variety of different laparoscopic simulation exercises. And this is a great way for them to learn a skill, but for us to also just get to know them, hear about the struggles that they have as residents and faculty, get a better understanding of how the system works, really just kind of chatting. And that is what then helps us figure out kind of what the problems are as they perceive them, what the things are that frustrate them on their day-to-day, and how we can potentially help sort some of those out. The next lesson I've most definitely learned is that all you really need is a knife and a fork. So in modern day medicine in the United States, we get very comfortable with all the fanciest and the newest and the brightest and the shiniest. And at the end of the day, it is often good to be reminded that we could take good care of patients with a bit less. This is the picture on the top left is of 2 residents doing a skin graft. The majority of us that do skin grafts, if we walked in and we didn't have the dermatome and the mesher and all the other fancy equipment that we were used to, would potentially consider canceling the case. They simply take an 11 blade and cut the skin off of the leg. They mesh it themselves and then sew it onto the wound, which again, in the United States and most places would be considered absolutely unheard of. Same thing with the instruments. We're used to, if the pickups don't pick up perfectly, if the scissors don't scissor perfectly, we toss them in a pile. And seeing that you can take the time to fix them, you can reuse them, is a valuable lesson, I think, for all of us. In the hospital where we spend the majority of our time in Hawassa, from a radiographic standpoint, you can get a plain film and then you can do a bedside ultrasound. The CAT scan exists and has only ever worked for 15 minutes in the course of the 6 weeks that I've ever been there. They had an MRI machine that was donated by the Chinese. It was installed. They turned on the switch, they blew a fuse, and they fried the entire MRI. So they have most definitely gotten used to taking really excellent care of patients with a lot less than we're used to, and doing a lot more of that bedside clinical judgment rather than running everyone through the donut of truth. So the picture on the left is a picture of Emmy Tesfaye, who is the, at the time when I first met her, she was the only critical care doc in at this hospital that serves a catchment area of 20 million people. They since have hired 1 other. So she arrived fresh out of residency and fellowship training and took over the ICU. This is a group of, the middle picture is a group of residents gathered around her as she does her bedside teaching on her ICU rounds. She runs an ICU of 7 beds. And this is, they're doing amazing care with, again, what we would consider to be less than optimal supplies. Third lesson is that just because it works here does not mean that it's the right solution there. Soon after I arrived in Ethiopia, I was spending a bunch of time with Dr. Emmy in the ICU, and I watched the way she resuscitated patients. And I was shocked by how little fluid they gave. And being the kind of Western trained physician that I was, and who had Rivers protocol drilled into my head throughout my critical care fellowship, I didn't understand, I poo-pooed her significantly for her lack of volume resuscitation. And she told me, anecdotally, she said, patients don't survive. They don't do well with that. And I, internally rolled my eyes and said, wow, we got a lot of work to do. Well, it turns out she was absolutely right. There was a study not long afterwards that came out of Zambia, a randomized control trial, that actually showed that the Rivers protocol, the normal resuscitation protocols that we use in the US, do kill patients in Africa. It's probably multifactorial. It's probably due to more systemic disease, more malnutrition, And as a result, the volume resuscitation leads to pulmonary edema, and in places where you do not have ventilators, this is a death sentence. And so it turns out that she was absolutely right. And so I swallowed my pride and admitted it, and then have really tried very hard in the work that we do to make sure that we're not just bringing our solutions to them, and believing that it's a one-size-fits-all kind of situation, because I think the increasing recognition is that that's just simply not the case. And that comes to lesson number 4, that one size does not fit all. In terms of when we think about global surgery, everybody wants to find the solution to solve the problem of the lack of surgical care around the world. And the reality is, when you look at this map that came out in the Lancet in 2015 and Global Surgery 2030, which was one of the seminal papers that was written, essentially showing that economically and not just humanitarian wise, it makes sense to treat surgical disease around the world, excuse me. This map came out showing on a gradation the number of people that do not have access to surgical care. And they define access to surgical care as being able to get to a facility that can do a cesarean section, a laparotomy, or care for an open fracture within 2 hours. So it's the majority of sub-Saharan Africa and almost all of Asia and parts of South America as well that fall into this category. But again, the belief that we are going to be able to find one solution that is going to solve the problem all over the country simply doesn't make sense. First of all, in my time in Colombia, I got to spend time in 2 different hospitals. One on the left is private, the other on the right is public. And this is chest tubes being placed in the resuscitation bays of each of those institutions. The one on the left looks like a hospital, looks like you could be in the freighter emergency room. That's the private hospital, as I'm sure you can imagine. The one on the right is the public hospital, where you will routinely find patients bagging themselves after they've been intubated, or an entire ICU of patients having to use one pulse oximeter. So the disparities are great. In addition, when you look at a map of Hawassa, this is the hospital where we work, down here on the left, Hawassa University Comprehensive Surgical Center. Less than a kilometer away is the Yanet Internal Medicine Specialty Center, and less than 3 kilometers away is the Trauma and Surgical Hospitals, both of which are private and actually happen to be owned by one of the pathologists at Hawassa. In Hawassa, we don't, like I said, we don't have a CAT scan. A good majority of our patients can't get labs because they can't afford to pay for them. And when a patient does need something like a CAT scan, if the family can afford it, what happens is they are placed on a stretcher and the family runs them down the road to the Yanet Specialty Center to undergo the imaging, to then turn around and run back. And when I figured all of this out, I asked, I don't understand. You tell me your CAT scan's broken, but obviously if the CAT scan down the street works, why can't we get our CAT scan fixed? And you won't be surprised to know that it's all an issue of money. So, and with that, when you think about the infrastructure in which you're trying to build, we're working now to help try and build a pre-hospital center in Hawassa. When you look at Hawassa, a place where here is the airport, it's simply, you essentially wait in a shed, you roll yourself down this broken down road and you hop on your plane. A lot of the car traffic is not car traffic, it's donkeys, it's motorcycles. The only time I ever saw an ambulance was when I ran a half marathon that was being sponsored by one of the former elite runners of the country, a guy named Hailey. The only time I ever saw an ambulance was when this nice woman that was running with me skinned her knee and the Red Cross showed up. But I've never actually seen an ambulance bring a patient to the hospital because the pre-hospital system simply doesn't exist. You go to this is Colombia, again, where I spent some time, again, a place where a good portion of the country does not have access to care within 2 hours. And if you're in a city, there are plenty of ambulances around, and the streets and the infrastructure looks much different. So again, trying to find solutions to provide access to care in these two different settings, both of which are considered low middle income countries, is just vastly different, and it's going to require a completely separate team with a different mindset. And as you can expect, with that comes that there are no simple answers. This is, again, a picture on the left of the ICU in Hawassa. The ICU in Hawassa is 7 beds. It technically is the public tertiary care hospital that covers 20 million people. So the numbers there obviously don't make sense. And how do you even start to tackle and address something like that? This is a list on the right of all of the blood tests you can possibly have run in the entire hospital, and the prices next to them as these patients' families are being asked to pay cash. Again, this is a system that needs a significant amount of work, and they are doing the best they can with what they have. In addition, culturally, the physicians are running up against significant kind of cultural issues and distrust of physicians. Traditional bone setters and healers are very common and very popular in Ethiopia, not just in the rural areas, but in the cities too. And when somebody suffers a fracture, they often first go to a traditional bone healer, and the traditional bone healer will wrap their arm or whatever, their limb with a piece of cardboard, wrap it then very tightly, provide some topical medicine, and then tell the patient, whatever you do, do not go to the hospital, because if you go to the hospital, they're going to cut your arm off. And so these patients will go home, they will be in significant pain, they will suffer a compartment syndrome due to the tight wrapping. And sure enough, by the time they've waited several days to weeks and they present to the emergency room, their arm is dead and they require amputations. And so this is a problem that the orthopedic surgeons that we work with in Ethiopia are really struggling with, to try and do an entire countrywide cultural campaign to try to explain to people, and this is the educated and the farmers, all aspects of life, that these traditional healers are really causing a significant amount of injury. In fact, one of the surgeons we work with has just begun a nationwide data registry to try to start to quantify how many patients suffer morbidity from these types of treatments, in order to be able to try and get some laws enacted at the federal level, the national level. In addition, I'd be remiss to not say something about the current political situation in Ethiopia. Ethiopia, this picture on the top right is of Ahmed Abiy, who is their current prime minister, who came into power about 2.5 years ago. The picture is of him receiving the Nobel Peace Prize in 2019. After he became the prime minister, after a significant period of in which the majority of the ruling party came from the northern region of Tigray, Abiy came in and essentially really preached the need to put tribalism aside and come together as a nation, and to be Ethiopians first, and to try and do what's best for the country, and to try and decentralize some of the power from this northern region. The region where we work is way down here in the south, in Hawassa. He opened up the borders with Eritrea and ended a long war with them, which gave them access then to the Red Sea, which helps with them from a commercial and trading standpoint, and is largely throughout the country praised for the work he's done. However, there are groups of particular tribalists, particularly in this northern region, who are less than happy with these changes in power dynamics. And that is what has led to much of the conflict that we're seeing and hearing about now. As Tigray tried to make basically a power grab and start a war, and Abiy's forces are now coming in to try to counteract that. And we're seeing a humanitarian crisis as people flee across the border into Sudan and Eritrea to try and get away from this fighting. This doesn't necessarily have direct impact all the way down here in Hawassa. It could, but that being said, I have my mentee who's currently working on a research project. I reached out to him last week because we were supposed to meet to go over his proposal to the ethics board. And he said, I haven't been able to speak to a number of my family members. I'm worried they're dead. I can't talk about this right now, and with good reason. So, you know, these are disturbing times in Ethiopia, and we're praying that Abiy is able to get things back under control, because he has done so much good for the country in the last several years. But obviously it's hard for us because we can't be there. And whether it's because of COVID or the civil unrest, we're worried about our friends. And so with all that, you know, kind of heavy news comes lesson number 6, which is, how do you eat an elephant? And luckily my daughter's not old enough to understand that I showed these pictures of her. But this is my now 7-year-old, who is an avid rock climber. She'll climb fences. She'll actually climb a climbing wall. And sometimes when I'm trying to get her in the shower, she's actually climbing the side of the house. And 2 summers ago, there was a big event in her life. One of a girl who is now her hero, named Sela Schneider, who climbed El Cap. She was the youngest person, not the youngest girl, but the youngest person to climb El Cap out in Yosemite. And she did it with her father. And she did a podcast in which somebody interviewed her about her experience. And somebody asked, you know, when you were up on that wall and you were so tired and you just couldn't believe that you were ever going to make it, what got you through? And she said, well, my dad and I used to always say to each other, how do you eat an elephant? And this was a line made famous by Desmond Tutu. How do you eat an elephant? In small bites. And so when I think about my global work, I remember that often, and just remember that all I can do is try and bite off the piece that's right in front of me, and try not to get so overwhelmed by all the things that could be. And with that comes the realization that innovation is essential. And in the US, we think about innovation as technology and, you know, how fast is your internet, and get me my G5 and all of these things. And there's plenty of that going on internationally and in sub-Saharan Africa, but innovation is also the little things. On the left, this is a picture of an ostomy bag made out of an old IV bag. And, you know, ostomy supplies are not seen in Hawassa, particularly at the public hospital. And so they're making do with a glove and a bag. Here on the top right is a lady doing her intensive spirometry using a glove. They give each patient after surgery a glove, and they're told to just blow it up a few times an hour. This is a friend who is a CRNA named Eleanor Mullen, who is at Mass General, who came with me on my last trip. And she spent a lot of time in the operating room with their nurse anesthetists, trying to help them figure out, how do you keep babies, children, adults safe in the operating room when you don't even have a working blood pressure cuff, and coming up with innovative ways for them to you know, check for oxygenation and try and keep these patients safe and do the best they can. In addition, here on the left, when I first arrived in the ICU, there was no hand sanitizer. And I said to Dr. Emmy, I said, we really got to do something about this. We you know, we're going to end up, because they're starting to have problems with multi-drug resistance. And so she said, give me a little time. I need to think about it. And she came up with the idea of pouring alcohol into containers, tying them at the bottom of the bed. And then she pushed hard over the course of the next several months to have a real cultural change and teach her nurses and residents and staff to be cleaning their hands with alcohol as they moved from one patient to the next. This is, they struggle with pain control in the post-operative period, particularly in children and babies. They have an amazing pediatric surgeon who's doing amazing work, but the majority of the drugs that they have available to them are simply not safe to give for babies in terms of analgesia post-op. So in conjunction with an anesthesiologist who came over, we started teaching them how to do tap blocks and regional blocks in order to be able to give the baby some relief, and then hopefully with a bit of Tylenol in addition, keep them more comfortable. And then on the top right, this is Bitsu. She's one of 2 female residents who's now in the program, and they are pushing hard to get more women into surgery and through the program, which is really obviously a cultural change. And these women, these 2 women, Bitsu and Betty, who are in the program, are just amazing. And I was lucky to get to spend some time with them. This guy in the middle is somebody who I spend a lot of time with. I probably talk to him 2 or 3 times a week. His name is Mengistu Gebrejones, and he is a trauma orthopedic surgeon. And he is one of the most impressive people I've ever known. He's starting his PhD while working full-time as an orthopedist at Hawassa. He is a big-time researcher and just an innovative guy. He had figured out that with femur fractures, getting people into traction splints, as we would in the US, number 1 was associated with such high infection, and number 2, they didn't have the beds in order to be able to properly set it up. So he figured out that you could put splints on people, attach this plaster U at the bottom, and then attach a weight, typically jugs of water, and provide enough weight in order to keep the people in traction until he was able to get them to the operating room. They also struggle with issues of open fractures and osteomyelitis long-term. And so he figured out a way to make a simple counter incision and bring the gastroc around in order to make his own flaps without the help of plastic surgeons, and is currently studying this to show that he's able to bring down the rates of chronic osteomyelitis and improve bone healing in the patients that he treats. Another lesson for me is that the variety is the spice of life. So I love the work I do at Schroeder. I love teaching. I love being in the operating rooms here, but I gain a lot by leaving and going to other places. And each side of my life kind of fuels the other piece. In particular, the people that I meet and the places I get to go. Hawassa is on this beautiful lake called Lake Hawassa, where you can go and sit and have a nice glass of wine and watch the hippos, some of the best bird watching in the world. We also spent some time, we used to go for morning runs up and down this hill. And this is a picture of us just stopping in the morning to take a picture quickly with a donkey. This is a group of the other surgeons and physicians that we get to work with when we're here. He's a radiologist. Mengistu, I already introduced. Mule is a neurosurgeon who spends time at the hospital. These people are just so dedicated and smart and technically so savvy. And it's really wonderful to get to spend time with them. And then there are not many other places where you can go and be attacked by monkeys while trying to eat your lunch. Or this was me doing this half marathon race, and all of a sudden I get passed by all the female elite runners in Ethiopia. And let me tell you, they are fast. They are really fast. Or driving around, and this is a Bajaj, which is basically a motor scooter with a tin can around it. And this one happened to have green shag carpeting as a roof, which, that's not something you get to do every day. And here on the bottom right is Dr. Robin Richmond, who is a trauma surgeon at Lubbock. She and I were actually residents together at GW and have been able to reconnect just by chance through this partnership in Ethiopia. And it happened to be that we were there at the same time, both teaching and working. Finally, if there's one thing that COVID has taught me, it's that the world is getting smaller. We had planned for an in-person research course to try and really jumpstart the research component of our teaching in Hawassa. I was supposed to be there at the beginning of May to do a 3-day intensive course, and then COVID happened. And as a result of that, we had to try to figure out what to do. And we made the decision that if we waited, we were going to just waste a lot of time and lose a lot of momentum. So we pivoted to a fully virtual 7-week course. Tuesdays and Thursday mornings, we had lectures. These times on this schedule are Ethiopian time. So we are 7 or 8 hours difference depending on daylight savings time. And then every Saturday morning, we did an 1.5-hour small group session, breakout sessions on Zoom. with our small group. So we started with 20 participants, 10 residents, 10 faculty. We lost a few along the way. There was some civil unrest in the middle of the summer in Ethiopia for several weeks, and the internet and Wi-Fi got completely shut off. And so the course got delayed. But in the end, we managed to get 12 people from the beginning to the end of the course, focusing on how do you come up with a research question? How do you critically read an article? How do you come up, how do you put together a protocol? How do you do data collection? And we've gotten all 12 of them to pick a question to walk us through what kind of study design they would choose for themselves. And they've now been each paired with an individual mentor, and they are working on ethics board proposals with the hope that we will reconvene in the spring once they've all had their proposals approved and be able to go through the nitty-gritty of how do you collect data and store data safely, and then how do you analyze data. We've been lucky to be able to partner with the public health school there. So we have 3 MPHs who are helping us with a lot of these lectures and serving as mentors. And this has been a great experience, allowing these residents and faculty to pick a question that they are passionate about and be able to start the process of answering those. In addition, we are working on starting a trauma data registry across all of Hawassa, so those public and private hospitals across the city, to try and start collecting some basic information about where are our patients coming from, what kind of injuries do they present with, what is their economic status, and what are their outcomes. We are lucky to be able to partner through our Department of Epidemiology with Laura Cassidy at MCW, who has experience building trauma registries locally in Milwaukee and doing a lot of disparity work, as well as in Nigeria and Sierra Leone. And she is well published and unbelievably well respected, and she is helping us through this process, which has been so great to be able to collaborate with her. And we hope within the next year or so to then be able to come back and feed that data back into helping us design this pre-hospital system. So it's really bringing together a lot of kind of spokes to a hub to try and be able to improve the care of the patients there. Obviously, we're starting with trauma patients because that is our area of expertise, but there are similar groups doing work from a surgical oncology standpoint. They're setting up oncology databases. There is a hospice group, there's a pediatric group, there's an anesthesia group, really all starting to try and collect data and be able to improve care in the region. And with that, I will say goodbye and thank you. I'm happy to answer any questions. This was my morning ride to work every day. And again, a picture of the lake.
Thank you very much. That was excellent. So I am wondering whether anyone has questions here. Dr. Kleinman?
Oh, I think you're muted.
I think you're muted, Jack.
I have a question while Tom Russell here. A number of years ago, there was an article in the New England Journal of Medicine about the benefits of checklists used in several areas of Africa. Did you employ some of those checklists in your work as well?
Yes, those checklists are very helpful, particularly in the peri-op setting. Yes, absolutely, they're being used. It is a big cultural change to really, it's hard to know how much it is that they're using them because we're standing there versus how much they've truly adopted them as part of the process. And that is one of the things we've worked very hard on, is having local champions and people who really own these projects. And so Dr. Yosef, one of the surgeons there, has taken this on as his own.
I think I'm unmuted now. It appears that Ethiopia, like some other places I've been, have a two-tier medical system, public system that's poorly funded. When I was in India, the public hospital looked like my medical school hospital in the 1960s, whereas the private hospital looked like the Mayo Clinic. So what I wanted to know is, are doctors split between public and private, or do they work in both places? How does this work out? What's the distribution of medical expertise and resources?
Yeah, that's an excellent question. So I can only really speak from the surgical and critical care side, obviously, but a lot of them get pulled at least part-time into the private sector because they simply need to in order to feed their families. So a lot of them have, one of the things that this partnership with the American College of Surgeons has done is bring in the opportunity for them to have academic advancement. They want to do research. They want to publish. They want to teach. And so they giving them the tools they need and the incentives in order to be able to stay on the public hospital side. You know, we're working hard to be able to give them those things. But in reality, most of them also have private practices where they are then spending, whether it's a day, a week, or even two, doing cases and seeing patients at the private hospital.
Yeah, I had a question. I was wondering what insights you think that people, that the physicians in Ethiopia, for example, would have about care here. I mean, what would they say that have for our care or healthcare system?
That's a very interesting question. They're all desperate to come see it. I can tell you that much. You know, they desperately want to come and see what we've created and how we innovate and be able to take those lessons back. When we start to tell them the nitty-gritty of the disparities within our own system, they're often shocked that, you know, that those exist, that those are not things that are necessarily unique to Ethiopia or sub-Saharan Africa. That's probably the most information I can probably give you about that.
Have you discovered that you are bring any tricks back from Ethiopia and apply them in your own practice?
I think that I am constantly reminded when I'm there the importance of my physical exam and my, you know, I mean, their ability to do a physical exam and look at a single plain film and make a complex diagnosis is impressive, and it's a good reminder to us all. In addition, I think I'm probably more frugal in the operating room than most. I can make one suture last an entire case, which again is a good lesson, I think, for residents. It's just a shift in the way you think and a reminder that there may be that resources aren't necessarily always going to be so plentiful.
Can I ask a question? Steve has talked about finding ways to have students spend 2 weeks in a global situation and 2 weeks at home to compare and contrast and learn. Is that something that you've been able to do in your experience? And what kinds of global surgical lessons can we teach our medical students to do exactly what you're talking about, to understand the how much we waste here and the difficulties that our global friends have?
Yeah, so I was lucky to be able to have those opportunities as a medical student, and I think they were invaluable. I mean, number one, from a pathology standpoint, I mean, I took care of a leper when I was in Zambia. So that's, you know, they're just from, and, you know, in a true AIDS and TB ward, just things that we don't necessarily see anymore. And I think that in and of itself is a valuable experience. I think that there's the lesson that we're probably more similar than we are different, which I think is an important lesson for all of us to remember, particularly those in medicine. And even if a student doesn't think this is something they want to do, they want to incorporate into their practice long term, I think it's an unbelievably valuable, can be an unbelievably valuable piece of their training. So the goal is, the program in Ethiopia is relatively new. The plan would have, I know that one of our residents from MCW, who's now actually one of our fellows, Becky Mitchell, came with Dr. Demoy and Dr. Jajan last year. I took a resident my last trip when I was at Rutgers. I think there has been discussion about making this a site for our students to be able to come as well. It's a really nice setup, particularly in Ethiopia. We have our own guest house, we have our own transportation, our meals are taken care of. So in terms of the logistics of bringing a student, they're all set up here in a way that's pretty darn ideal. So once the borders are open, we 100% hope to be able to do that. We're also in the process of starting a global surgery research fellowship, in which one of our residents will come spend 2 years, hopefully get the Masters in Global Disparities that Dr. Hargarten spoke about at the beginning. And in the course of that, also then be able to go spend some time in country, like 6 months, and be able to do some local on the ground disparities work. So I think there's lots of opportunity, whether it's in Ethiopia or elsewhere.
I got a question. What type of trauma did you see in Ethiopia? Is it automobiles or the type of trauma we see, kinetic trauma we see in our cities?
Yeah, so it's probably a few more impalements by bullhorns than we see here, although I will tell you that we had one of those not too long ago at Schroeder. It's a lot of motor vehicle accidents. I've never seen, there's a lot of motorcycles and I've never seen a helmet. So, and people ride 3, 4, 5 deep on these motorcycles and the roads aren't very good. So it only takes one bump to send somebody flying off the back. Part of the trauma registry that we're trying to do is to get a better idea of what the mechanisms are, because we don't really have, because the records there are still on paper for the most part, we don't, everything to a certain extent is anecdotal where we are. And getting an idea of what the true catchment area is of this hospital, how far people are coming from and what kind of accidents they're happening, and potentially where. Is there one specific area that we really need to go and address geographically, is part of the work that we're trying to do.
I have a question for Steve Hargarten. Has there been any adverse effect of the recent hurricanes in the southern part of Belize on the clinic down there?
Thanks, Tom. We have not heard anything that's been adversely affecting specific areas due to the weather, but we do know that they're starting to get strained with COVID. And one of the emergency physicians that we've been collaborating with over the last decade is actually now the chief of staff of the hospital, the main public hospital of Belize. And she was saying how they're starting to get challenged with COVID cases. So while the hurricanes, when they do come, present a emergency response requirement, the main issue right now is the COVID response.
Is hostility towards white doctors a problem that you had? I lived for a year in the former Belgian Congo, and it was extreme.
Wow.
Not in Ethiopia. So the Ethiopians are unbelievably welcoming people. And I think particularly under Abiy, there is a lot of excitement about innovation and investment in the country. And so we are unbelievably welcomed from the moment we arrive. And I think that that is more and more the case across the majority of Africa. I know that hasn't always been the case.
For Dr. Hargarten, you are sending a lot of people. You sent a lot of people abroad, and I'm wondering what kind of preparation they are getting for the a cross-cultural experience and sort of the dealing with a concept of morality and appropriate behavior.
Well, that's a good question. And actually, we have been very, very forthcoming and forthright about preparing our students, our residents, and when appropriate, even our faculty to participate in pre-travel, pre-clerkships, if you will, that are outside the United States. And in fact, with the scholarship program that we have with our students and residents, again, grateful to donors, both in the private sector, that if you're going to accept the travel scholarship, it's required that you go through this pre-travel course that we have put together, and it's well received. And we feel this is an extremely important element of preparing our students and residents to be respectful and accepting the challenges that they're going to be facing, and do it in a respectful way to the country that is hosting them. So it's an ongoing area that we look at very, very carefully. And we work closely with our partners to assure that our learners are learning appropriately, if you will, from their colleagues in the other countries.
So do we have any other questions?
I have one last question. I was in Kenya for several weeks last year, and the Chinese are, from a geopolitical perspective, are extremely aggressive, particularly in Kenya. And I know that they are building a port or a location in Djibouti. And you mentioned the Chinese donating a MRI apparatus or CT scanner. Are they, the Chinese, very active in Ethiopia? Do they have a lot of natural resources that the Chinese are pursuing?
Yeah, the Chinese just built them a brand new airport in Addis, and a brand new quote unquote 5-star hotel across the street that's already falling apart. They've built a lot of roads, which there are already issues with. They come in fast and they build quickly, but the quality of the work they're doing is being questioned. But yes, there are a lot of natural resources, and then because of now that the border is open with Eritrea, the ability to get, one of their big resources is coffee, to then be able to get that very quickly to the Red Sea, as well as there's a lot of minerals, particularly in the south. And the Chinese are building quickly to get their hands on that.
Wow.
One of the reasons perhaps that whites and Westerners are not are received kindly in Ethiopia is that, other than the Italian campaign of Mussolini, Ethiopia was always an independent country for 1,000 years, I guess. And so it didn't suffer under the same kind of colonialism, for the most part, that much of the rest of Africa did.
Yeah, I would agree with that. I think, again, it's probably region by region as well. I lived in Kenya for about 8 months as well, and they were unbelievably welcoming, despite the colonialism there. But they did quite well under Kenyatta, and so I think there are definitely within Kenya the haves and have-nots, but the physicians and the people that for the most part I was spending time with were very welcoming.
That's good. Okay, anybody else? Comments, questions? Thank you, Dr. Hargarten and Dr. Schroeder. I think these were very interesting presentations, and I wish we could travel again and personally see some of these places. I'm looking forward to it, but first I have to visit my grandkids.
Fair enough.
Those are priorities, Jack.
Yeah, exactly.